Welcome to the deep dive. Today we're getting into something pretty serious, one of the most uh, complex fields in surgery, radical and reconstructive procedures in gynecologic oncology.
Yeah, this is really the advanced stuff.
It is, and we're going to synthesize the history, the anatomy, and the outcomes to create a sort of roadmap for anyone who really needs to understand the deep pelvis.
Exactly. Our mission here is to deliver a really thorough but, concise understanding of these procedures. This isn't just a list of facts.
Right.
We need to get into the principles, the why behind it all. Why did the surgeries change? What can't be compromised? And what are those critical trade-offs between a cure and, well, a patient's long-term function?
Okay, so let's unpack this. And a good place to start, as always, is history. The battle with cervical cancer is ancient. We're talking nearly 2,500 years.
It's incredible. Even Hippocrates, back around 460 BC, was attempting something called a trachelectomy.
Just removing the cervix.
Just the cervix.
Yeah.
But he even noted that the disease usually came back. I mean, the technology, the understanding, it just wasn't there yet.
So it took a long, long time for that leap to happen.
Centuries. The real pivot point was the late 19th century. And it wasn't one single invention. It was a crucial anatomical realization. And that moment really came from John Goodrich Clark at Johns Hopkins in 1895.
And what he found is just staggering. He reviewed hysterectomy specimens for cervical cancer.
Yeah.
And in 15 out of 20 cases, 75% of the time, the tumor had already spread beyond what the surgeon had actually removed.
Right there. That's a 75% failure rate. It just tells you everything about the limits of what they were doing at the time.
So what was his critique? What were they doing wrong?
His critique was, well, it was revolutionary. He said surgeons were cutting the broad ligaments way too close to the uterus. They weren't taking wide enough margins, and they were removing too little of the upper vagina.
They were aiming for simplicity, but it wasn't working.
Exactly. And at the same time, you have the surgeon, Reis, in Germany, developing the theory that you needed to systematically remove pelvic lymph nodes.
So you have these two ideas converging. Clark is saying you need to cut wider locally, and Reese is saying the disease is spreading systematically through the lymphatics.
Precisely. They were attacking the same problem, how cancer travels, from two different angles. And this fueled a huge debate in the early 20th century.
The abdominal versus vaginal approach.
Right. You had Schoda, who was a big advocate for the radical vaginal hysterectomy. But it was Ernst Wertheim who really championed the abdominal approach.
And his procedure was formidable for the time, wasn't it?
Oh, absolutely.
Yep.
By 1912, he'd published results from over 500 cases and got the operative mortality down to 10%, which for that era was a huge achievement.
And here's where it gets really interesting, because this connects directly to the procedure we know today. We have to jump forward to 1944, Joe Vincent Meigs.
Meigs is the one who put it all together. He took Wertheim's big abdominal procedure, and he incorporated Reese's crucial idea about the lymph nodes, his modification. Well, it was the game changer.
So he extended the Wertheim operation to include
Complete, bilateral, pelvic lymphadenectomy. And his first results for stage 1 cancer showed the 5-year survival rate just shot up to over 81%.
which leads to this great irony we have today. In the U.S., a lot of people still call it the Wertheim operation.
They do.
But in Europe, they often call it the Meigs operation because they're crediting that critical extension that actually made it curative.
It's a perfect example of how science builds on itself. And that brings us right to our next point, the anatomical foundations. You just can't do these surgeries safely without mastering the pelvic architecture.
Okay, let's talk architecture. The uterus is suspended by 5 paired ligaments, but for a radical hysterectomy, which one is really our primary focus?
The main target, without a doubt, is the paired cardinal ligaments, also known as Mackenroth's ligaments. They're these massive fibromuscular structures that anchor the cervix to the pelvic sidewall.
And why are they so important?
Because they're the conduits. They carry the bulk of the neurovascular supply. We're talking the uterine artery and vein, other vessels, and critically, the autonomic nerves going to the bladder and rectum.
So dissecting the parametria means you're right in the middle of all that critical plumbing and wiring.
Exactly. And speaking of plumbing, the major blood supply all stems from the common iliac arteries. But there's one technical detail here that's vital for reconstruction.
The inferior epigastric artery, the IEA.
Yes, it comes off the external iliac. And you have to know this because if you think you might need a rectus abdominis flap for reconstruction later,
A big muscle flap to close a defect.
Then you cannot sacrifice the IEA. That's its primary blood supply. You have to preserve it during the lymph node dissection. It's a perfect example of planning the closure before you even start the main resection.
It's like chess, thinking several moves ahead.
It is. And speaking of tools, let's talk electrosurgery. It's a cornerstone of this kind of dissection. How do we explain the practical difference between monopolar and bipolar energy?
Okay, so the biggest difference is where the electricity goes. With monopolar, the current flows from the instrument through the patient's whole body to a distant sticky pad to complete the circuit.
Which is great for wide field work.
Great, but it has a risk, right? If that pad has a poor connection, the current can find another way out and cause a burn somewhere you didn't intend.
Whereas with bipolar, it's much safer in that respect. The return electrode is built right into the forceps, so the current only passes between the two tips of the instrument.
Much more localized. Great for sealing small vessels. And what about the waveforms? Cut versus coag.
Think of it like water from a hose. Cut mode is a continuous, steady stream of current. It generates intense heat really fast, vaporizes the water in the tissue, and that's what creates the cut.
A clean dissection.
Right. Coagulation mode is more like a pulsing sprinkler. It's an interrupted current. Staccato bursts. That intermittent heat desiccates the tissue and forms a coagulomycele without instantly vaporizing it. Great for stopping bleeding.
That makes it very clear. Okay, so we have the tools, the anatomy. Let's look at a really extensive procedure. A combined radical hysterectomy with a vaginectomy. When is that necessary?
Generally, it's for two main reasons. The most common one is for early-stage vaginal pansurphago stage I, or I, that's localized to the upper part of the vagina and has invaded the tissues around it.
The pericolpium.
The pericolpium, yes. The other indication is when you have an early cervical cancer, but it's combined with vein vaginal intraepithelial neoplasia.
A precancerous condition.
Exactly. And since vein can be multifocal, sort of scattered around, you might need to remove a large part of the vagina to clear that entire premalignant field.
Which brings us to a really crucial classification, the parametrectomy types, C1 versus C2. This directly impacts the patient's outcome.
This is non-negotiable. Anyone learning this have to understand the difference. Both are radical, but the real distinction is the fate of the autonomic nerves.
Okay, so let's start with type C1.
Type C1 is the nerve-sparing procedure. The whole point is to preserve the inferior hypogastric plexus and the splanchnic nerves. So you have to keep your dissection plane above where those nerves are running. You carefully peel them away from the specimen.
So you get the cancer out, but you leave the nerves that control bladder and bowel function intact. What about the more extensive type C2?
A type C2 is the extended procedure. Here, you're aiming to remove the majority of the parametrial tissue, including the part where those nerves run. So as a trade-off for getting wider, safer margins,
You have to sacrifice the nerves.
you have to sacrifice them. And that sacrifice is the #1 driver of long-term functional problems. It's why you only escalate to a C2 when you absolutely have to.
And before a surgeon commits to either, you need really accurate staging. What's the gold standard there?
For local staging, seeing how big the tumor is and if it's invading the bladder or rectum MRI is the gold standard. It has amazing soft tissue contrast. But if you're worried about spread outside the pelvis,
Metastases.
then PT scanning is the most accurate tool we have.
Got it. And a quick but important point. Mechanical bowel preps. They used to be standard. Why did we abandon them?
Well, the logic seems sound, didn't it? A clean colon is a safe colon if you think you might have to open the bowel. The idea was it would reduce infection or leak risk.
But the evidence didn't back that up.
Not at all. The evidence showed it does not reduce the risk of an anastomotic leak. And worse, it was causing systemic problems, dehydration, electrolyte imbalances that could lead to things like acute renal failure. The risk just wasn't worth the non-existent benefit.
A great example of evidence-based practice changing dogma. Okay, let's shift to the most complex end of the spectrum. Pelvic exoneration, PE.
This is the biggest operation we do. It's usually for recurrent cancer, often after radiation, where the tumor has invaded adjacent organs.
So who is the ideal candidate for such a massive surgery?
Typically, you're looking for a young, otherwise healthy patient with an isolated recurrence right in the center of the pelvis. But the absolute paramount goal is achieving negative surgical margins, what we call an R0 resection.
Meaning zero microscopic disease left behind.
Zero. If you can't achieve R0, the procedure is futile and the outcome is dismal. That's the litmus test.
And what are the absolute contraindications? When do you just not proceed?
Any sign of disease outside the pelvis. So grossly positive aortic nodes, peritoneal metastases. If the cancer has already escaped the central pelvis, a curative exenteration just isn't possible.
So, assuming we proceed and the bladder is removed, we need to create a new way for urine to get out, urinary diversion. For the incontinent options, what's the preferred method?
The preferred ureteroidal anastomosis is the Bricker anastomosis.
And why is that preferred over, say, the Wallace technique?
It's all about protecting the kidneys. With a Bricker, you implant each ureter separately into the piece of ileum, so if one of those connections were to get a stricture or scar down, it would only affect one kidney.
Ah, I see.
With the Wallace, you sew the ureters together first into a single opening. So a stricture there could block off both kidneys at once, leading to bilateral hydronephrosis and renal failure. The Bricker is just safer. It doesn't put all your eggs in one anatomical basket.
That makes perfect sense. Now, what's the predictable long-term metabolic side effect of using a piece of bowel to channel urine?
The key one is hypochloremic acidosis. It happens because the bowel segment, which is designed to absorb things, starts reabsorbing chloride from the urine and kicks out bicarbonate in exchange.
So you lose base, and your blood becomes acidic.
Exactly. And if that chronic acidosis isn't treated, it starts to mobilize calcium from your bones to buffer the acid, which can lead to severe osteopenia over time.
So what's the fix?
It's actually pretty straightforward. Patients often require prophylactic alkalinizing agents, usually potassium citrate, to counteract it.
Okay, let's close the loop and talk about survivorship. The patient experience after all of this. What's the most common acute complication?
Delayed spontaneous voiding. It's extremely common, especially after a C2 procedure where the nerves are gone. Patients just can't empty their bladder properly.
And how is that managed now?
The standard of care is to place a suprapubic catheter, not a traditional Foley.
Why is that better?
A couple of reasons. It has a lower risk of UTIs, and crucially, it lets you do voiding trials much more easily. The patient can try to pee normally, and then you can just unclamp the tube to measure what's left behind, the post-void residual or PVR.
And when the PVR is consistently low, the tube can come out.
Right. Once it's consistently under about 80 ml, they're good to go.
And what about long term? What's the most frequent persistent problem?
It's still urinary bladder dysfunction. Things like incontinence, not being able to feel when your bladder is full, having to strain with your abdominal muscles to void, and the data is crystal clear. The frequency and severity of these problems go way up as you move from a nerve-sparing C1 to a nerve-sacrificing C2 procedure.
So survivorship is so much more than just being cancer-free. It's about quality of life.
Absolutely. And that's where physical activity and rehabilitation come in. It's been shown to reduce fatigue, stress, even recurrence risk.
No.
We also talk a lot about self-efficacy.
The patient's confidence in their ability to manage things.
Exactly. And we've seen that interventions combining weight loss and exercise can actually have a measurable positive effect on quality of life and self-efficacy scores in cancer survivors.
That really does summarize the balance, doesn't it? It's this constant push and pull between the curative intent, getting those R0 margins, and minimizing the life-altering morbidity.
It is. So before we wrap up, let's leave you with a quick review question to really hammer home this core principle.
Okay. If a patient requires an extensive radical hysterectomy, a type C2, what is the expected critical difference in postoperative functional outcome compared to a nerve-sparing type C1 procedure? And which specific autonomic nerve structure is primarily at risk during that C2 resection?
The answer to that question really gets to the heart of the main challenge in this field, because while our survival rates are better than ever thanks to these huge operations, the ongoing frontier is not just about surviving the surgery. It's about optimizing functional recovery and quality of life when those essential nerves have to be sacrificed for a cure. That balancing act, that is what defines success.